Next speaker is none other than Mahipal Sachdev, a champion of champions, and he will be sharing his experience of ICL in difficult situation and intraoperative and early post-operative complications.
Thank you very much, Purender. I'll be showing about complications because champions make most complications. So anyway, a lot of part of it has already been shown, but post-op management, topical steroids, antibiotics, and pressure-lowering drugs for for few days that is there. Post-op evaluation, when a patient comes, I normally don't do both the eyes together. The next day morning, I see the vision and I also see the vault of the patient as to how the patient is doing so that it can give you an idea vis-a-vis whether there is any sizing problem, etc., the IOP and the centration and the positioning. So this is how you have to look. If you just have a slit lamp, OCT can give you the best thing, but on a slit lamp you can see that thickness of the cornea and what it is, the gap between the lens and which should be about 500, 600. So that's where you can. So it's very easy even on a slit lamp to measure the vault. Now I'll just show you certain complications which could just listed it. And this is one thing that is important is that once you are doing cataract surgeries, you also think that you can do an ICL, but you need to look at it. So one important thing is that it need not be a wound assisted, and if your wound, if the ICL gets stuck in the wound, like it is getting stuck here, it has a tendency to roll over. So that is important that we have done this, but I normally don't say this that you can rotate it, but it depends at the level at which it is opening, and you can withdraw it. That is very easy, and then you don't damage anything. But one important thing is that proper, like Tityal showed it earlier, like IPCL has different, acryl phakic now, Oro has also come out. I don't know what is their placement. So किसी में उल्टा डालना पड़ता है, किसी में मतलब upside you have to put, I think, in acryl phakic. So you need to know beforehand, do dry this thing, that what is the right side up and how you have to do it. Uh, this is thanks to Dr. Ram, basically on the Varion. I think he has also showed it. So you can see that there is a positioning problem that is there. This is where it should be. So you can go back and reposition it at whatever it is. Now this was a curious case that we had where we did the lens, the position rolled over. We again went ahead and did the whole situation. That means we rotated it. But when we did the anterior, we could see that possibly there was a little bit of a dialysis unexplained that was there, and despite having dialed and redialed it, so what lies in the sulcus is actually not known to you at times, and that could be a problem. So best thing in this particular case was to go out and just explant the lens, which I'm just showing you. It's a hand over hand technique. Get one edge of the haptic and just pull it out, and that's what it is. So this is one thing. Now this is a prospective outcome. I have never had it with ICL, but this patient was given to me. They told me, and the patient had a 618 plus 1, and as Ram told, spherical equivalent all, you had a plus 1.2 and minus 2.5. So I said why it is. So I went ahead. I did the dilatation, and I looked at the alignment, and the alignment was bang on. It was 160 degrees that they had told me, and I was at a loss to say that they have given me this particular chart and it is still on 160. And why is it? The moment you have a plus and a minus, be sure that it needs a redialing. It's very clear that it needs a redialing. I did an eye trace on it, and the eye trace told me that I have to rotate 31 degrees anti-clockwise. And lo and behold, I rotated it and I got a 6-6 vision. Now the company has still not replied to me, and I won't leave them. So basically, I think most probably it's a calculation error that is there. So despite my having doing an ICL since 1999, this is the first time I had, and this is with ICL that I have had, that when I rotated it down 10 degrees instead of up what it was at 160, I've got a 6-6 vision now. But it's better to cross check as to what has come and what needs to be done. So that is something important. Raised post-op IOP pupillary block is one of the things. Can you see in this OCT? This is basically an inverted ICL. Ulta dal diya hai, and you going to have a pupillary block, or you can actually have a lot of pigment dispersal. You can have retained viscoelastic, and you can even have malignant glaucoma that can happen. So if there is a push on the iris, you can have it, because nowadays we are not doing a peripheral iridotomy, and the best thing is to immediately do an OCT, or if you can dilate, and you need to pull out the lens and put it back the way it is supposed to be there. There can be a steroid response. You can see this is again a high vault which the OCT can tell you, but normally an 850 vault I can leave. it tends to settle down. But if you have something more than 1000, 1200, you need to watch over a couple of days. The vault just tend to come down a little bit. But you should not allow pass to form at that particular time. Low vault is it's a small size lens, so you have a low vault, you can have toric ICL rotations, which can cause a problem, early cataract formation. This is retained viscoelastic. The central hole has helped reduce this kind of an anterior subcapsular cataract. If viscoelastic was trapped, and specifically if it was HPMC, you could get anterior capsular this thing, but the central hole, now you can push fluid through it so that the central part is clear, or use it also for aspiration. So we don't get this anymore, but if you have this, we can easily just do a flax or do a explantation. The only thing is that the pupil is always misread as the optic of the ICL. The pupil, as you can see, is small, so we dilate it, and then you have to actually bring the anterior capsule onto the position, and then you can do a femto or you can do a normal one. Always use trypan blue, and so that even if there is some incomplete capsular access, you can actually take care and you can go ahead. This is an LRI. Normally, when you, the only problem that we have is this is a 3-piece lens. Normally, these are high myopes, and you don't get toric lenses in these power IOLs that I am talking about. So that's a problem that you have. Either you do a brush up LASIK on top of it, or you do an LRI, etc. And normally you have odd power only Technis, Sensor, etc. or those kind of lenses that you have. So these are a couple of things you have. You can have endophthalmitis in particular cases, because it's an intra. All the asepsis have to be done. You can have problems of when it started, when we were doing an iridotomy surgical, I made a CI instead of a PI. So there were a lot of complications that have happened, but it's been a learning curve. But one important thing is, if you learn the process, it's a good, simple process. It's giving excellent outcomes. It is being used, sorry, I need to change the slide, but procedure of choice, I have now brought it down to 8 diopters. Any irregular corneas, LASIK rejects, etc., and new models are increasing, and whether the phakic presbyopic implants are going to work or not, that's the ultimate answer that is there. So I think you can all adapt this particular technology if you are doing a cataract surgery. Thank you very much for your kind attention.
Thank you, Dr. Mahipal. Any questions? We can take one or two questions.
Refraction should be stable and topography should be stable. That's about it. Yeah.
Minimums 6 months or maybe one year. That is always better. But 3 consecutive topography should be taken. Yeah.
Hanji.
Any other question?